Okay, so I'm here today with Dr. Pete Thurley, who's a consultant radiologist at the Royal Derby Hospital, and we're going to talk today about interpretation of the abdominal CT scan. So welcome, Pete. Thanks for coming.
Hi, John. So what we'll do is look at a few examples of some sort of pathologies you might see as a surgeon on call, and I'll just show you how I approach a CT. The best way, really, I find is to be quite systematic, just so you don't miss anything out, just like approaching any other type of imaging.
Mm-hmm.
So when I first get a CT through, obviously exactly what you do depends a bit on the indication, so the clinical information is crucial. But in order not to miss anything, I tend to go through in a certain order. So to start with, I'll look at the lung bases.
So there's a lot of people going to be watching this who haven't really had much experience with CT. So the black stuff it depends how you set the windows, but the black stuff tends to be air.
Yeah, that's right. So without getting too bogged down in the physics, exactly the window you use will depend a bit upon what you're interested in. So, for example, you can see at the bottom of the screen there you've got some numbers which give you the window width and the window length, window level rather.
Yeah.
So the idea being, the way CT works is you have information from the machine which gives you a value for how much radiation a voxel, which is like a little cube of tissue, absorbs. So air doesn't absorb very much, whereas bone absorbs a lot. So on this you can see the bone is white and the air is black.
Yeah.
If you wanted to look at the lungs, we'd change the windows so you could get a better idea of what the lungs look like, and that would be involved changing the window level and window width. And all these presets are available on all the PAC systems.
Yeah. So we've got it set to an abdominal.
Yeah. So for this one, I would look at the lung bases on lung windows to start with. Once I'm happy there's nothing major there, I then go through all the solid organs on the CT. So to start with, look at the liver.
Mm-hmm. So this is liver over here.
Yeah. So I'll have a look at that with the normal abdominal windows, which we've got on at the moment. I'd also then, if it was say a cancer staging scan, I'd probably look at it with liver windows, and that's a special window where any little focal bits in the liver will stand out a bit more. Mm-hmm. And again, those presets are available. So have a good look through there. This is also, these are axial images, so cross sections, and most CTs give out these cross sectional images. But you can also get other views, so you'll get coronal images, which is as if you're looking from the front, or sagittal images, which is if you're looking from the side. I find particularly the coronal images are good for looking at the liver as well, particularly if you've got a little lesion tucked up under the diaphragm, because it can be quite difficult to see on the axial images, whereas it might be very apparent on the coronals. So once you look through the liver, I then look at the gallbladder, which is this slightly lower attenuation area here, so slightly darker area. It's got fluid and bile in it. The other solid organs you need to review are the adrenals, so these little Mercedes type shapes of structures here. So those are the normal looking adrenals.
But when there's an adrenal mass, it looks different. There's a lump there where the little Mercedes thing should normally be.
Yeah, so you'll get a mass lesion, so that normal shape is distorted. And a lot of radiology is as you know, is pattern recognition. So it's just a matter of looking at lots and lots of scans, and you'll get your eye in as to what's normal and abnormal. So these are normal adrenals. Kidneys next, and again I think coronal images, so looking at it as if you're looking from the front, are really helpful for picking out little little renal lesions. So I'd go for a coronal view of those as well. Next, look for the pancreas. So this is the pancreas here. The tail of the pancreas, this is the body of the pancreas coming around towards the head. And you can see this slightly lower attenuation area in the middle, that's the pancreatic duct.
Yeah.
So we have a look at that for masses. Also look at the duct size, because an enlarged pancreatic duct can often be a secondary sign you've got some pathology going on in the pancreas, so that's useful. And then last of all, the spleen. This is an arterial phase image. You can tell that because there's lots of contrast in the aorta there and the major branches of the aorta. This is the IVC over here, and there's no contrast in there because the images are being acquired quite early on.
So the contrast hasn't circulated and got to the veins yet?
Yeah, exactly. So for a standard CT abdomen, you might you do it in what's called portal venous phase imaging. That's about 70 seconds after injecting the contrast, and this is the portal vein here. Yeah. And on portal venous phase imaging, that'll be full of contrast, and it also just makes liver lesions more conspicuous.
Yeah.
On the arterial phase imaging, of the spleen, you can see it looks a bit blobby and a bit heterogeneous, and that's a normal looking spleen on arterial phase imaging. Now this patient was sent in with a suspected rupture AAA, which is why we did the arterial phase imaging. And as you come down through these slices, you can see the aorta is grossly abnormal, really dilated. I think this was about a 10 centimetre aneurysm.
Yeah.
As well as that, you can see this little crescent of abnormal tissue outside the lumen of the aorta, and some of that is, as you can see at the top there, is the duodenum, but this bit here is actually a hematoma, so this is a ruptured aneurysm.
So you can see lumen there with contrast in, and then some thrombus. Yeah,
you quite often have, well, almost always within abdominal aortic aneurysms, you'll have areas of thrombus with it, and that in itself is a normal finding. This has got quite a big flow lumen. You can see all this contrast here, blood flowing through, but there is stuff outside the aorta as well. There are various other secondary signs of rupture. So you have impending rupture. You'll have the aorta draped over the vertebral bodies at the back here. So this is one of the lumbar vertebral bodies. You can have an odd morphology to the aneurysm sac. Sometimes you have like beaking, or if you've got calcification in the wall of the aneurysm, which you often have, if you have an interruption of that, that's often a sign if you've got an impending rupture. But obviously, clinical findings like a tender aneurysm are equally significant. So anyway, so we're looking at the aorta here because this is a scan done in arterial phase looking for the aorta. You can see the major branches coming off here. So that's the celiac axis there. That's the SMA coming off down here.
So that's T12, L1. So T12 for the celiac axis, L1 for the
and then
SMA.
L1-2 where the renal arteries tend to come off.
And there's one other side.
Yeah, that's right. And they are slightly variable where the renal arteries come off from. They don't always come off at right angles at the side there. There's often, you can see accessory renal arteries. I don't think there is an accessory in this case, but they're always worth looking for. And also important if you're planning some sort of intervention for this kind of thing.
Yeah. So lots of these get stented now, and you want to know where the renals are, because if you put the stent across the renals, that's bad news. And you can put stents down the renals, or have little slits for the renals, but you need to know beforehand. So. Yeah,
and generally for emergency ones, though some centres will treat aneurysms with stents into the visceral arteries. Generally for ruptures in the acute setting, because you don't have time to get a special graft, you need to make sure you've got a neck beneath the renals to shove your graft in.
We have in this one.
So, for this patient, we know the diagnosis. If we were just approaching it and we hadn't seen anything else abnormal, our next step would be to look in the retroperitoneum around the aorta, looking for nodal disease, and tend to go all the way down the aorta and also then down both iliacs, looking for any nodal disease or anything abnormal along there. In this case, we already know the diagnosis, and that's less relevant. Once I've looked at the nodes, I'll look at the colon, and the colon is quite tricky to assess on a standard CT because you often have faeces in the colon that can mimic tumours. This patient's got a bit of diverticular disease there. You can see.
So there's lots of little. It's quite a little bit thickened. And some air pouching.
Yeah. These are little diverticular, and the thickening is related to the sort of smooth muscle hypertrophy as part of the disease process. But it's always worth looking at the colon, because although you will miss subtle things because of the faeces and it's not dilated, you can occasionally pick up very large masses, which are obviously significant. So once you've done that, I will have a little look at the small bowel to make sure there's no small bowel dilatation, which there isn't in this case. And then,
can you just point to a bit of small bowel?
So these loops of small bowel up here, you can follow it around from the this is the stomach coming down into the proximal duodenum. In this patient, the duodenum stretched across the aneurysm before it gets to the DJ flexure, and you can see more pelvic loops of small bowel lower down. So other way. So all these are loops of small bowel which are collapsed, and that's normal appearances of a small bowel on the CT.
And if you're looking at that specifically, you'd have some oral contrast.
Yeah, so if you're particularly looking for small bowel pathology, there are various ways of investigating that. You can give oral contrast for CT, and if you get good small bowel distension, you can get really nice pictures for the CT. So last of all, after I've looked at all the bowel and the nodes, I then go back and look for destructive bony lesions. And again, sagittal and coronal views, so side-on and front-on views, are really nice for looking at the vertebral bodies. In particular, that'll show you if there's any wedge fractures or anything like that. And obviously we'd also change our windows to bony windows, which show the bones a bit more nicely. So these are some coronal views of the same patient. So this is if we're looking from the front. You can see how you can appreciate the vertebral body
Oh,
heights.
the kidneys look
nicely.
Really different, don't they?
Yeah, so you get a better overview of the kidneys, and looking at things in more than one plane, you're more likely to pick up such little masses. It's really helpful. And the other thing, as I was saying earlier, if you look at the liver, especially here, just under the heart, where there's not really much liver tissue, and you can get sort of partial volume artifact because it's so thin. Looking at it in a different plane often is really helpful. I tend to review most CTs with cranial images, so they're particularly helpful for looking at the bones, but also for the solid viscera, I think. And also, if you see something on an axial slice and you think, well, that looks a bit odd, I'm not sure exactly what it is, or if it's normal or not, you could then go and interrogate on a different plane, and it can often be really helpful. The other thing with CTs of the abdomen, if you're a surgeon, is you want to know if there's any free fluid or free air. So once I've looked through everything, I'd change it to bone windows and look through on axial and coronal images, looking for free air, because that will really stand out.
Right.
You look for free fluid.
That stands out as very black.
Yeah, so that'd be completely black on all windows, no matter how you window it, and they'll be much more apparent on the bone windows or lung windows. And free fluid, again, is an important thing to look for. It tends to sort of occur in predictable places, so checking the pelvis, especially behind the bladder, looking for free fluid, and also around the spleen and the liver, you can often have a little rind of free fluid there. So that's
and that looks, it's a slightly greyer, lower attenuation thing. Wouldn't you see that?
Yeah. So it's sort of similar attenuation to the gallbladder there. So lower attenuation to the viscera and also to your muscles, but slightly brighter than the fat, which is very dark, but not quite as dark as the air, as we've said.
So you've been going, so looking at a CT, so we've got a system now for checking things. You've been going sort of up and down, backwards, forwards, kind of making your own video from these individual screens. Is that the way to do it? It's just not one image, but go up and down. I think
when you first start looking at this, it's important just to go through one image at a time, look at it all really carefully. Yeah. But as I was saying before, so much of radiology is pattern recognition and just looking at things over and over again. And you'll find that as you get more experience in looking at them, things will just jump out while you're just scrolling through, because it'll just stand out something you don't normally see, and so that's quite a useful way of doing it.
So let's say you're a medical student or foundation doctor or core trainee on call or in the clinic. How are you going to get good at these? What would you say you need to do?
It is just a matter of looking at lots and lots.
With the report afterwards, so you see what you saw, and
I think if you have the clinical information and you know the question you want to know the answer to, you can then focus what you look at, and then you can check your findings with the report. The other thing is most images are reviewed in MDT, so MDT is a quite useful way to go and pick up a lot of knowledge, I think, from sort of all the specialties. You'll pick up gems from that. And the other thing is, if you have an interesting scan, take it to your local radiologist. Hopefully they'll be happy to look at it with you and talk you through it and answer any questions. And certainly if you've got an interesting case, they'll probably be quite keen.
Yeah, no, I always found that a great help.
So we've had a look at a patient with ruptured aneurysm. This is another patient who was admitted under the surgical team.
So you get a request. How important is the information on the request?
Radiologists are always going on about how we like clinical information, but it is critical in terms of you will tailor the type of scan depending on what the question is. I mean, that's critical. When you're asking for a scan, what we want to know is what is the question you need answering. And we sort of touched on this a bit in terms of having special preparation for the bowel.
Yeah.
But say we were worried about bowel ischemia or some arterial problem, then we'd definitely include an arterial phase on the scan. So say if you're worried about GI bleeding, for example, you'd certainly include an arterial phase in the scan. Whereas, so timing the intravenous contrast is a big thing. Sometimes you don't need intravenous contrast. For example, if you're looking for renal stones, having the bright renal stone as on the background of an unenhanced kidney is very easy to see. Whereas if you contrast, it can actually paradoxically make it more difficult to make the right diagnosis. So it is absolutely critical.
So you're not just being grumpy, it actually makes it to what you do and then the result you get in treating the patient. So
some of the times we're not being grumpy.
Yeah,
that's right.
That's only some of the time.
So this patient was someone who came in with abdominal pain. The question mark was whether the patient was obstructed. So as before, we start with the lung windows, looking at the lung bases, go through and look at the liver there, and you can see the gallbladder there. Yeah, that's a bit more distended, so that's probably because the patient's fasted and not eaten. The rest of the solid viscera look pretty normal again. We've looked at the adrenals, the kidneys, the pancreas, the spleen there.
Is there something extra?
I'm sure your eagle eyes have already picked out the abnormality here. So this is a great example of a patient with some bowel pathology. So this is the ileum coming down towards the ileocecal valve.
Yeah.
And as it passes up, you can see this very abnormal looking bit of bowel, and you can see this cuff of fat around the small bowel as it's going into the colon. This is a patient with intussusception. So you've got the bowel being pulled through within the large bowel, with this fluid and fat around the outside. And this was a patient who had a malignant lesion near their ileocecal valve, who was presenting with intussusception. But then it's really important to carry on going through the system. So there's this expression called satisfaction of search, and it's when you're looking at some radiological test, you see an abnormality and you immediately feel triumphant and switch off because it's like, right, I've spotted what's wrong, I can now relax, my job's done.
Yeah.
But actually, particularly for something like this, you need to then look around and see what else is going on. So, for example, it'd be really useful to know whether there's been a perforation, so you'd look carefully for free air. This is a malignant lesion, so you want to make sure there's no metastasis. So you can see there's a few little nodes here in the mesentery, these little white blobs here are lymph nodes. But it's very important to then go and look at the bones, make sure they've got bony metastasis. And go and you probably want to do a CT scan of their chest to complete staging, so have a really careful look through that. So it's important not to get carried away and just relax as soon as you spot one abnormality. You need to still kind of keep your system and make sure you go through things really systematically. So these are the coronal images. So again, you're looking as if you're looking face to face with the patients, and that's quite nice because you can see the bowel going up with the fat either side of it, intercepting into the.
You can see the loop. Really quite nice, can't you?
Yeah, no, it's quite useful. And you can see the appendix poking out around the side there. That's the appendix being sucked into the.
You can see that that turnarium, is it?
Yeah, that's right. Yeah,
you see it going in there. That's really quite something.
And again, quick look at the liver there, just to make sure there's no metastasis, especially in that left lobe, where it's a bit tricky to see. But, yeah.
And the small bowel looks a little bit more blown up on there.
Yeah, there are a few loops, aren't there, that look quite prominent there, so maybe they are intermittently obstructing, which wouldn't be surprising really, given what that looks like. So this is a patient who came in with acute pancreatitis and wasn't very well. A lot of abdominal pain, obviously, but also a drop in the haemoglobin, so we did a CT scan. And there are obviously lots of different types of complication of pancreatitis you can see on CT. You can look for biliary dilatation, you can look for pancreatic necrosis, pseudocysts, other collections, inflammatory masses, that kind of thing. The other important thing to look for is vascular complications. So in this patient it's quite nice because you can see the splenic vein really clearly, especially on these coronal images. So that's the splenic vein going out towards the splenic hilum there. And you can see it coming over to the midline here where it joins with the superior mesenteric vein to make the portal vein going up there.
Yeah.
Those are the kidneys there. And this one, as I say, you'd start with the lungs, and there's something to see in the lungs here. You can see this is an air bronchogram here, and you've got a bit of fluid at the base there, at the left lung base, with a bit of associated consolidation. Again, with the inflammation you get with pancreatitis, you often get changes in the lungs. There's more consolidation there on the left and the right. Liver looks okay. You'd be worried about some biliary dilatation. You can see that's the CBD there, maybe a tiny bit plump, but not significantly dilated. And importantly, there's not really much in the way of intrahepatic duct dilatation. You can just about make up the right-sided ducts there running next to the portal vein branches. And the same on the left there. You can just about make out some small intrahepatic ducts, but they're normal. No liver lesions. We've looked at the adrenals, they're fine. Kidneys look alright. Spleen there. Occasionally get splenic infarcts and things, but that looks okay again. So this is the pancreas. And you can see around the pancreas there's loads of stranding in keeping with the pancreatitis. You can see that the pancreas itself is enhancing normally, so that's good. You can't see any evidence of pancreatic necrosis.
So if it's necrotic, it doesn't get a blood supply. and so it doesn't light up when you put the contrast in.
Exactly, yeah, and again, that's when timing's critical, because you want to give the contrast when the pancreas is going to be at its peak enhancement, which is arterial phase, maybe a bit later, about 45 seconds. So yeah, you look for bits of the pancreas where there's gaps of the normal tissue. You see the pancreatic duct normally, although that's not at all dilated, so that's normal.
Yeah.
If you had a patient with chronic pancreatitis, you'd be looking for those sort of changes too. So that would be things like pancreatic parenchymal calcifications, or a dilated ectatic duct and ectatic side ducts. And sometimes you get very atrophic pancreases if you've had a lot of pancreatitis. This patient's got another vascular complication though that you sometimes see with pancreatitis, and that's a pseudoaneurysm. So a pseudoaneurysm is basically when you have a defect in the wall of an artery and you have a contained leak effectively. And that happens in pancreatitis because you get all the nasty pancreatic enzymes released, and they sort of bathe the vessels, and there's lots of blood vessels around the pancreas. There's a rich blood supply coming from the SMA and the celiac axis. And this patient has got this big blob here. You can see that's the same kind of attenuation as the blood vessels. So this is contrast that's just been injected, sitting in a little pseudoaneurysm. And around that you can see all this stuff here, and this is haematomas, this is blood. So blood on a CT, again, it's a bit brighter than normal fluid, normally about 60 to 80 Hounsfield units. We used to
we can look it up on Wikipedia. There's a good page on Wikipedia at Hounsfield units. Yeah.
Very, very briefly, Hounsfield units is a measure of attenuation. 0 is the number assigned to it, so anything that's fluid intensity. Anything like bone will be several hundreds, and air is minus several hundreds, and everything else is in between.
And he was from not too far from here, I think, Hounsfield.
Is that right?
Yeah.
So, so this is a pseudoaneurysm, big hematoma around it. There's some blood in the bowel as well, and this is someone with pancreatitis. We were talking about earlier a bit about free fluid, and this is quite a nice example of free fluid in the pelvis here. You can see these are loops of bowel, these slightly brighter bits, and in between it this irregular low attenuation stuff is fluid, maybe a bit of blood mixed in with that.
And that's the same shade of grey as the other blood you saw before, or pretty close to it.
Well, this bit here is hematoma,
Yeah.
that bit there, which is similar to the blood in and around the duodenum.
Yeah.
This darker stuff is just free fluid. You can see the difference there, and that dark stuff is much more similar to
so
the
there's
gallbladder
liquid
there.
blood and hematoma.
Yeah,
Right.
yeah, and completely fresh blood that hasn't clotted will be
Yeah.
slightly darker than clotted blood, which you can see the stuff in the left side of the abdomen is.
Okay, that's great. So, well, thanks. We've seen some really interesting scans. Just take us through your method for looking at any CT.
So first of all, read the clinical information very carefully, because that's often a good pointer as to the question you need to answer. Then if you're just going through a standard abdominal CT, there is a clear system to go through. So personally, I start with a lung basis, so I don't forget them, put lung windows and go through making sure there are no big lung masses or consolidation or pleural effusions. Next, I move on to the abdomen and look at the solid organs, so in particular the liver. Then I'll look at the gallbladder, adrenals, kidneys, pancreas and spleen, carefully looking for any focal lesions, any masses, and looking on the coronal images as well as the axial images I think is key for those. Once done that, I move to the retroperitoneum and we'll go down and look for paraortic lymph nodes, then also look in the pelvis to make sure there are no lymph nodes next to the iliac vessels, which is where you commonly see them. Once done that, I'll go through the colon, and that sometimes takes a bit of doing, going up and down. It can be quite wiggly, but you just follow that all the way around, making sure there aren't any large masses there. You have to accept the limitations of CT, and you'll certainly miss small polyps. You may even miss small malignancies if there's a lot of feces or the bowel's collapsed. But have a look anyway. And then look for small bowel, looking for small bowel dilatation in particular. If you do see that and you're worried about small bowel obstruction, you need then to follow the small bowel around, looking for where there's a change in the calibre, to look for the transition point and the cause of small bowel obstruction. Once done that, I'll look at the bones and change to bony windows and look at it in multiple planes, particularly sagittal and coronal planes for the bones. And again, with acute abdomens, it's very important then to look through for free air, and whilst you're doing that, you can look for some free fluid in the pelvis and around the liver and spleen. There are other little things you might want to do depending on the clinical information. So Certainly if you've got a history which might suggest bleeding or might suggest ischemia, you'd look very carefully at all the blood vessels. And that, as well as the arteries, that includes the veins. Sometimes, patients with SMV thrombosis can present with abdominal pain. So the vessels are something else to look at. But again, you will slightly tailor what you do depending on exactly the question you need to answer.
Great. Well, Pete Thurley, thank you very much indeed.
No problem.